started.
All right, welcome everyone. Good afternoon, and thank you so much for joining our webinar today. I'd like to introduce our two speakers and also give them an opportunity to introduce themselves. So today we have Dr. Carlita Warren. She is the Assistant Program Director of the Master of Science in Community Medicine program. We also have Dr. David Lawrence. He was appointed as the Dean of KGI School of Medicine recently. So I'll hand it over to you both. Thank you so much.
You want to start, Dr. Warren, just asking the students to introduce themselves and sort of saying a little bit about what we're doing, and then I can talk about precision health.
Sure, thank you. Welcome everyone. It is good to have you here this evening. Tonight we are going to give you a brief overview of the importance of precision health and what precision health entails. But before we do that, since we have a manageable group here, if you wouldn't mind, it would be great to have you all unmute and introduce yourselves. Let us know what major you're interested in. I know you're completing it on the form, but if you could just introduce yourself and tell us what major you're interested in, that would be great.
And also, it would help if you feel comfortable doing so. Help be fine to see you in Zoom too, to have put a face with a name if we can. If you don't mind, that would be great. But if you do that, don't worry about it.
Perfect. Thank you so much, everyone. We can start off with Angel. Angel, if you would like to unmute yourself and introduce yourself, that would be great.
Hi, everyone. My name is Angel. I hope everyone is listening me well. And yeah, I graduated from a master program of bioinformatics 2 years ago. And the reason why I'm joining today is just to hear about the trend and what are some of the exciting researches going on in the clinical world as well as in the scientific world. Yeah, thanks for having me.
Good. Nice to see you.
Angel.
Nice to see you.
Robert?
Hi, my name's Robert. I graduated from UC Irvine 2 years ago in public health science. I'm interested in the PharmD program, and since I'm here for the precision health Zoom meeting because I'm interested specifically in pharmacogenomics. So there's a lot of cross-pollination there.
Thank you, Robert. Nice to see you.
Thank you so much, Robert. All right, up next, Kelly.
Hi, I'm Kelly. I graduated from UC Riverside last year, and I'm interested in the genetic counseling program at KGI. And I'm really interested in precision medicine, just learning more about that and what encompasses it.
Great.
Perfect, Kelly. Thank you. Jessica?
Hi, my name is Jessica. I'm on the bike. I got off work right now, so I wanted to make it to the meeting.
And it's not stationary, is it?
Gas is almost $8. So anyway, I graduated from California State Northridge, major kinesiology, exercise science. I'm interested in community medicine, master's in community medicine. I was looking into life applied sciences because as a kin major, a lot of research was done. But yeah, I want to be a healthcare provider. I've been in the healthcare field for quite some time now, so I have the experience as well. But MSCM is something I really look forward to getting into.
I've got to tell you, we've had lots of interesting firsts, but this is the first time that I've been introduced to a student riding a bicycle.
Riding a bicycle.
Stationary. That's amazing.
Here I am.
Way to go. Way to go.
Thank
That's a good way to do it.
Thank you so much, Jessica. Stay safe, please. But thank you for coming to our program today. Dr. Warren and Dr. Lawrence, I'll turn it over to you both.
Okay. Let me jump in. I'll talk a little bit about precision, what we mean by precision health. And I'm not going to talk about the application necessarily to genomic counseling or to the PharmD program at this point, but please ask your questions as you make the connections in what I'm going to say. There are a couple of terms of art that are beginning to emerge in the healthcare field. One of them is precision medicine, and the other is precision health. Precision medicine is referring to the use of the emerging, typically two kinds of data, the data that emerge from the intermolecular study of genetics and proteins, to some extent metabolic products, but the primary work is being done in genetics and genomics and also in proteomics. And fundamentally what it is in that field is the study of proteins circulating or genes found in the body and identifying or linking them with, through the use of massive data analytics, biocomputation, machine learning, AI, linking them to specific disease conditions, either as a predictive analytic for somebody who may have a disease in the case of genomics, or an actual early diagnosis in the case of protein. As you know, the proteins are kind of the tip of the spear with disease. They are what are produced by the genes or aberrant genes. And so we believe that the proteomic signatures that people have are much more specific for specific diseases. The protein signatures that people have are remarkably predictive or descriptive of a particular disease. And that's why we call it precision medicine. It is one patient with perhaps an illness who is either diagnosed through the form or the method of genomics and also proteomics, and a signature is found for that particular individual that is matched then with a known condition with that signature. And with that, what also happens with both genomics and with proteomics is that we are increasingly able to match a specific treatment against a specific protein or genomic signature. That is precision medicine. Many of us believe that over the next 20 to 30 years, that will be how diagnosis and treatment decisions are made in the clinical setting, by doctors, by nurse practitioners, physician assistants, etc. That this information is so precise. It is far more precise, of course, than the phenotypic information that we use now to make diagnoses and treatments. The kind of thing like, what do you look like? What are you telling me? What can I feel? What can I see on very crude laboratory tests? They seem very sophisticated, but they pale in comparison to the information that we can have about genomes, the genome, and proteomes. We think that approximately 22,000 proteins are associated with different diseases. At the present time, the science enables us to identify about 10 to 12,000 of those at one time on a single chip. A company called SomaLogic went public earlier this year and has the technology to do that, and has been working for the last 20 years actually to match those signatures with known medical conditions. The primary work in SomaLogic and in proteomic diagnostics and therapeutic decision-making is in the metabolic syndrome, cardiometabolic syndrome, diabetes, obesity, heart disease, inflammatory diseases, things of that nature. But it's being spread more and more widely as more and more samples are obtained, and more of that matching process between observed protein signatures in a given patient with an unknown condition is matched with something that is known, and we can then make the diagnosis that is definitive or decide on the treatment. In the case of treatment decisions, the primary areas where genomics is used, but also to some extent proteomics, is in the field of cancer diagnosis. As you know, we're getting more and more precise about the nature of the cancer aberrations, the mutations that occur, the multiple upsets in the intracellular systems. And with that knowledge, we now are able to match a specific condition in a specific patient to the best combination of medications for that particular situation. So that rather than saying, if you have a cancer A, the standard of care is to treat it with therapy A or B, what we now can say is neither of those is really a match for that particular aberration and won't work at the cellular level. Let's move on and try some other combinations to see what works, and it could be treatment C, D, E, or F. Those studies are underway now. Those developments are occurring now. It's moving sort of into cardiac disease and into some inflammatory diseases as well. Again, the prediction is that with the combination of genomics and proteomics, those powerful tools to actually do what in effect are images of your cells, what's going on dynamically in your cells, and using the complexities of biocomputation, as I said, machine learning, AI, which moves far beyond the ability of the human mind to understand and make those connections. We are able to come up with precision in the way we do medical diagnosis and medical treatment decisions. That is what we mean by personalized medicine, a diagnosis that is specific to you based on your unique set of genetic and or proteomic aberrations, and a treatment that is precisely tailored to those aberrations in you. Let me give you an example of how different that is and how different it's going to be and how important it's going to be going forward in medicine. When I was trained in medicine, and it's still true today, that if a child has an ear infection, the typical treatment is some broad spectrum antibiotic given at a standardized dose, whatever the dose is for the weight of the child. It's titered to the weight of the child. Now, we don't know if the child is going to respond, other than generally speaking, they do because of a particular presence of a particular pathogen. But what we don't know is the child's ability to tolerate that dose, or even if that child is going to have a special metabolic response to that drug that may result in an allergy or an allergic reaction, or may just render it not very useful. The same is true in treating people with pain. People have very, very different pain tolerances, very, very different pathways for dealing with drugs that are identified with pain relief. And so the idea of being able to understand what's going on at the molecular level, the intramolecular level for an individual patient is a remarkable advancement over saying, look, you're 12 years old or you're 8 years old and you weigh whatever your size is, say 40, 50 pounds or something like that. This is what we do for people with that. Whether or not it's going to work for you, that's what we had. Now, in the future going forward, we'll be able to say this will work for you because we understand what's going on inside your body with your genes, with your proteomes, with your cells. And this is the most likely treatment for you, given you. So we call it N of one person, or precision medicine that is highly personalized to the individual. So that's precision medicine. Now, precision health is a more recent addition to the way we describe the use of those tools. So it is still proteomics, it's still genomics, it is still massive data analytics, but it is also using other forms of data to identify people, not at the individual level, but groups of individuals in a particular population who may be susceptible to or may have early signs of illness that they're not aware of. And through the use of proteomics and genomic screening, through the use of massive data analytics in the form of socioeconomic data, demographic data, very similar to what, for better, for worse, Amazon does in trying to get you to move you towards a particular book or to buy a particular product. That's all the same kind of thing that we're also doing in healthcare, which is trying to understand what is it about you and your genome and your proteome and your particular situation that is similar to other people, and we know is associated with either the likelihood of developing a disease, hypertension, heart attack, cancer, stroke, lung disease, etc., or is an early diagnosis before you're even aware that you have it, so we can intervene early. So precision medicine is what a doctor provides or you will be using to diagnose and treat a specific patient sitting in front of her. Precision health is what we use in better understanding what's going on in a community and better identifying which people in the community we should really focus our attention on to provide them with the tools they need to either prevent the illness they have a risk of developing or to keep it from moving into an actual real illness that's going to cause morbidity and possibly mortality. So what we've done with precision health, and the person who introduced that term really is the dean of the School of Medicine at Stanford, Lloyd Minor, he wrote a book about it about 3 years ago. It really is the marriage of those intracellular capabilities, the new science of intracellular diagnostics, genomics and proteomics, the growing capability of massive data management and biocomputation using machine learning and AI, artificial intelligence, to identify who we should focus on or what the issues are in a particular community. But that's not all. What we do in the department, in our program in the Masters of Science in Community Medicine, for example, is not only that, but we then marry that with the ability to communicate with, establish trust with, work with, motivate, organize programs and interventions at the community level with members of the community to deal with the information that we've been able to obtain, both through precision health interventions or studies, as well as with communications or discussions with the community itself. So what we're using are these new emerging scientific tools and the massive data analytics that go with it, with skill development in communications, community activation, community motivation, and most importantly of all, learning how to establish trust at the level of the community, to work with communities to improve their health and lower their burdens of preventable illness. That's basically what we're doing with precision health. That's why we've introduced that into our program at the Masters of Science in Community Medicine, why we built what we have in the curriculum to provide not only the strong scientific background in the sciences of community medicine, which, by the way, are not calculus or physics or even biochemistry or organic chemistry. Those are not what we need at the level of working in a community. We need the sciences of human motivation. We need the sciences of change leadership, of quality management, of program design and program management. We need the sciences of how you use, not necessarily at the deep sort of basic science level, but what it means when you find protein signatures or genomic signatures. People working in the community in the master's program are not going to be doing those studies themselves, but they need to understand what they mean and how to use the information or interpret the information in a way that the community can use effectively. So that's what we're focused on when we talk about precision health. Now, all of the indications that we have from where the research is going and being focused, the state of the developments that are occurring and the speed with which they're developing indicate that both precision medicine and precision health are radically transforming the way medicine and healthcare is practiced and delivered going forward. It is a radical change, a sea change in the way in which healthcare and medicine is practiced and organized. Now, it turns out, unfortunately, that very few medical schools are preparing people for it. It's only just a little bit of the curriculum in the traditional medical schools. Some of the more innovative schools of medicine, schools of osteopathy, dentistry, pharmacy, et cetera, are spending more time in this field, but it is still new. And many are reluctant to embrace it and give up what we've done historically. That's not the case with our Master of Science in Community Medicine program. We basically are all in. This is where it's going. We want people to graduate from our program who are expert in that area, expert in the skills required to work at the community level, and giving them the tools that they need to do that effectively. We use an expression in our program that innovation and change at the community level sort of progresses at the speed of trust. And so what we really are talking about is building the skills, capability, the intellectual understanding that allows you to establish a trusting relationship at the community level so that you actually can help communities utilize these exciting new and emerging tools of precision health to make changes at the community level in their health status and in the levels of the burdens they bear of preventable conditions, both illnesses and injuries. Let me give you one final example and then I'll stop. In the National Health Service and also at UC San Francisco, studies have been done with proteomics. And it's fascinating. One of the professors of cardiology at UCSF was interested it was hard to explain why some men, in this case, who had one heart attack had another one. And what we do and have done historically, actually ever since a study came out called the Framingham study, is we treat everybody who's had a first heart attack the same way. Lots and lots of rehab, lots and lots of cardiac conditioning, lots and lots of medications, lots and lots of time spent getting people to come back in for follow-up sessions, etc. But what's interesting is that not everybody who's had a heart attack has another one. Now, what we've assumed historically is, well, they just did their rehab better. But it turns out that's not the case. It turns out there is a protein signature, a collection of proteins identified through a protein array, a sample that I mentioned, doing studies of their protein array, that a signature for the people who are most likely to have a heart attack within the next 24-month period, and those who are not. And it is quite different. So what this enables physicians in the National Health Service to do, and the cardiologist at UCSF to propose, is that those who are likely to have a heart attack have the protein signature that would suggest they are at much higher risk of having a second heart attack. They're the ones on whom you concentrate the preventive work, the rehabilitation work, the educational work, the change in diet, the change in exercise, stress, all the things thought to contribute to that probability, to try and get them to reduce the probability that they're going to have one. The presence of the protein signature doesn't say you're going to get one. It just says you're much more likely to have one. Whereas you can then ease up in what you're doing with the patients or the people who have had a heart attack who don't have the signature, because the chances of developing a second heart attack are very, very low. You can manage them quite differently. Now, the same is true with hypertension. The same is true with the sort of the precursors for diabetes and whether or not people are going to respond well to insulin with diabetes, et cetera. All of those things. And you can do that for individual patients, and you can do that for clusters of patients. I will give you one more example. Excuse me, I said I wasn't going to, but it's a different approach. And that is an approach that actually was developed in Israel. And it is in a company called Medial Early Sign. What a beautiful cat. And here's what they did. They said, I wonder if there is a cluster of data about the sociodemographic information and medical information that allows us to identify subsets in a population who are likely to benefit from having colonoscopy because they appear to have characteristics of people who have more positive colonoscopies than those who don't. It doesn't say you're likely to have cancer, but it's likely to find a positive finding on a colonoscopy. It's called a colon flag. And indeed, after going through, circle after circle after circle, iteration after iteration after iteration of looking at different hypotheses, collections of data, and literally doing this over 1 million times with different combinations and kinds of data, it's kind of looking for a needle in the haystack, trying to find the needle, which is in fact the collection of data that allows them to say, these people will benefit from having colonoscopies. Well, the interesting thing is in the hospital and health system in Israel where it was done, it was indeed found that these people had much higher positive findings on a colonoscopy. And frankly, early stage cancers were found more frequently as a result. Now, this is just an example. This was applied at several healthcare systems in the United States. Same model, lung cancer the same way, hypertension, another way, several more sort of what were called predictive analytics using the tools of massive data analytics. In this case, not proteomics, not genomics, but just basic medical information and basic sociodemographic information. looking for the patterns in those data that match with higher probability of having a positive colon cancer or colonoscopy screening. That's the sort of thing that is moving forward. That's another form of precision health. So those are what we mean when we use these terms, precision medicine and precision health. Many of us believe that it is the future of medicine, of medical diagnosis and treatment, as I said, and the future of community medicine, the ability to work with individual communities to improve health and lower their burdens of illness, of preventable illness and injury. It's not enough alone. It has to be coupled with, as I said, with those skills that establish trust, communications, ability to motivate communities, etc. And also some specific tools that have been found to be quite useful in working effectively with communities to apply these emerging sciences. So let me stop there and see if you have questions. I don't know, but before I do, Dr. Warren, do you have anything to add to what I said?
No, I don't. I'll just wait to see what their questions are, and then we can go from there.
Good, thank you. Okay, questions?
I just wanted to say thank you for clearing up the difference between precision health and precision medicine. A lot of people confuse the two all the time. So
they use the two interchangeably, and it's not, because remember that it's kind of, thank you, Robert, it's kind of interesting because if you stop and look at how we spend money in the United States, it's really fascinating. 90% of what we spend in the United States for healthcare is for the care of chronic diseases. That's astounding. You know, things like heart disease, cancer, Alzheimer's, etc. Many of those are preventable. And yet virtually all the money we put into the healthcare system is to take care of people who are sick. Now, we don't have many tools or many people trained to actually go upstream and use these emerging sciences to actually help communities avoid getting sick, or identifying who's going to get or who is sick and getting them very early so that the interventions, the therapeutic interventions, the behavior change interventions, the lifestyle interventions can actually make a difference. It's interesting, in the United States, actually across the world, we don't have people who are trained to do that. They're not using these emerging sciences yet. They're not using the analytics yet, or the other kinds of tools that I mentioned, but we're just beginning to. And that's really why we started the Masters of Science in Community Medicine. You know, it is not to say that you don't need more doctors and PAs and nurses and pharmacists and dentists and so forth, but they take care of sick people. They're not set up to work at the community level. That isn't what they're trained to do. And they're using precision medicine because they're dealing with one patient at a time. We're talking about applying the same tools and adapting them to the care of a community. I hope you're sitting up and not having fallen over on your bike, Jess. That you are, you're vertical, not horizontal.
Safe and sound now. Thank you.
Hey, Dr. Lawrence, this is Johnny.
Yeah.
So because this is all very new to me as well, and I really appreciate this opportunity to learn, I'm curious, are they able to just take the demographics to utilize some of these emerging technologies? Or are they having to come up with new lab tests for specific groups in order to find out how to utilize all this community medicine? One
of the really interesting things about the science is there are always new tests, and there's always new therapeutics. As you know, Robert's wants to go into the PharmD program. I mean, the development of new pharmaceuticals and new therapeutic interventions just continues at pace. It's quite remarkable. So that's always going on. But what's really interesting is that in the case of Medial Early Sign, the company that has been doing this in Israel and in the United States, they are using, as a matter of fact, they're using sociodemographic information and basic information in the medical record, CBCs, just blood studies.
Okay.
You think very simple things, it's all there. But what what the analytics give us the opportunity to do that the human mind cannot, frankly, it's just not capable of, is to find connections, to find correlates, to find things that are linked to each other. And when you pull them out and identify them, they become a kind of signature. And they're a signature that is predictive of something. It's linked to something. But you can't do that with a human mind. Our mind is really able to capture probably, I think the studies indicate that real geniuses are able to manage maybe 7 to 8 variables at once in trying to unknowns at once in trying to solve a problem. But as you get more information like 22,000 proteins, goodness gracious, you're so fast past that capability, there's no way the human mind can do it. And that's where biocomputation, where massive data analytics come in, the machine learning and the AI. That's how you find these connections. And I mean, it's astounding to watch this happen. I've actually seen this occurring when we've had a patient with a cancer diagnosis and we're trying to come up with the right match for therapy. And what it does is you plug in the specific model of the patient's cell, dynamic model of the patient's cell, and then you throw that up against up to 150 different therapeutic agents whose pathways are known intracellularly, some approved for cancer, some not. And it turns out that what you come up with is a cocktail typically of 2 or 3 medications, some of which are complete surprises, but they are the cocktail that will work for that patient. And of course, the test is what happens to those patients when they get that cocktail. And the interesting thing is that in the clinical studies that are now going on at a number of cancer centers around the country, the patients achieve improvement in their clinical status as a consequence of these. Now, there's very few medications that you can give that actually cure or reverse cancer. Typically you stop it for a period of time, and then there's a recurrence. We've delayed it, but we've only in a few cancers have we stopped it as a destructive sentence for an individual. And that's all great. It gives you more years of quality life. But we haven't figured out cures for cancer yet, for many cancers. But what this does is to give people some breathing room. And it's very interesting. This is an anecdote, but it was in a study of the first, I think, 40 of these patients who had gone through all the standards of care for a particular cancer diagnosis. And so under the aegis of the Food and Drug Administration's, there's a particular pathway for end-of-life care interventions that are unusual. And it's sort of when all else fails, here's where you go and you can get authorization to try something different. So in about 30 to 40 of these sort of last chance kinds of decisions, all but one had improvement in clinical status using this model. The one who didn't was the situation in which the oncologist didn't believe the recommendation and chose not to add one of the medications that was recommended through this iterative process because he just couldn't make it work in his mind. That's the kind of, so it's a long answer to your question, Johnny, but it's a combination of different forms of data that are used. It isn't so much finding a new test, one new answer for what allows you to diagnose something. That'll happen too. But basically what we're saying is, as we know more about proteins and we can identify them in their various forms and their various mutations, and particularly as we have the capability of identifying more and more circulating proteins, either in blood or in urine or in saliva, of those 22,000 proteins, there's plenty of information there to radically improve the way we diagnose and treat people over how we're doing it now.
Wow. So exciting and so interesting. Thank you for sharing all that, Doctor. I really appreciate it.
Sure. Yeah, it is really exciting stuff. Other questions?
I think you did such a good job that nobody has any idea what to ask.
Oh, come on. I don't believe it. I can see everybody sitting back there. I don't understand this, or should I ask this question? What's really going on with that? Don't be afraid. I mean, my gosh, that's the way we learn, is to ask questions. And what I love is being challenged a little bit to see if if the answers that I have or what I know can be useful to you, or to point you to the places to look if I don't. So please don't be shy. Don't be embarrassed about your questions. They're all legitimate. This is a brand new field. Believe me, everybody's kind of, it's a little bit like, 7 blind men trying to describe an elephant. Everybody does it a little bit differently. We're sort of in the early stages of what we're doing in this whole field. And it's mind-boggling what's happening, and so promising. I mean, and where we already know how it can be applied. But the fact is, it's confusing. It's kind of wild. So please ask your questions.
I was just wondering, those studies with the different cocktails of different medications for the cancer patients, I don't know if you know, but were those medications like specific therapeutic range, or were they like broad therapeutic range?
Well, there are, according to the studies that, or the review that the company that I'm familiar with, which you might look at, it's a very interesting company, Robert. It's called CellWorks. It's one word with a capital C and a capital W. And there's a description of it, its science and how it goes about doing this. But essentially what they did was to review about they found the drugs for which there is detailed intracellular pathway information, studies available. And they were able to put that into an analytic model that was a dynamic model. And then as they have the model of how a person's intracellular system is working, they can match that to different models, to different drugs. So I'll give you one example. One of the things that was recommended in one cocktail for one patient included a blood thinner that doesn't have anything to do with cancer. But we did know, they did know, not I, but the scientists and the clinicians who were doing the studies did know that had a well-described intracellular pathway, and it did something, I can't tell you what, but it did something inside the cell that facilitated the effectiveness of 2 other elements in the cocktail. That was the drug, by the way, that the oncologist refused to agree to believe had anything to do with it and was going to help. So you're not just using cancer, sort of cancer-approved drugs. In this particular pathway through the FDA, we can use non-cancer drugs together with cancer drugs. So it's a combination. I think there are 125, 130 of these drugs that for the pathways that are that well known, and more coming. There's another pathway being studied, which is another fascinating area, which, by the way, costs people enormous amounts of pain and discomfort. And it's a very expensive way to do this. The way we treat cancers now is we come up with a diagnosis, let's say glioblastoma, and you have sort of first stage drugs, second stage, third stage drugs. This is the first drug you start. In this case, here's the second one with these indications. Here's the third, here's the fourth, here's the fifth, here's the sixth, and then you're out of luck. So you go through those, but it turns out that different forms of glioblastoma respond differently to those 6 or 7 different drugs. But at the present time, we use the recommendations from oncology specialists as to what the first line drug is and what the second line drug is and so on. And that's how you make your choices. But it turns out it's not as good as doing a matching process. So now what is being done in clinical trials is trying to see, and they are producing those results that are demonstrating that we get better results if we use this matching process through CellWorks, for example, rather than the sort of algorithm that was developed by oncology experts based on inadequate information and incomplete information, but their own practice experiences. So it's just a fascinating area that's occurring, and what it raises, and this is an ongoing dialogue with the FDA, of course, because as you get into this kind of a capability, it challenges the idea of indicated drugs and non-indicated drugs or off-label drugs and so forth. But if you have a platform that is legitimate and robust, you can come up with off-label drug uses that are actually very well matched to the condition of the patient. But we have to have much more data that shows that before I think the FDA will agree to that. You look puzzled, Jessica.
No, it was really interesting. I know you said this is. I wanted to ask if this can be used more for behavioral health as well, like with their type of medication that they use. You know, schizophrenia, bipolar disorder. Is this something that can be used for that as well?
Well, that's certainly where it's going to go. I mean,
Okay.
for certainly the medication side of mental health disorder treatment, that kind of model will apply. Same with addiction, other things like that. So, but we need much more data, much more experience before we know the specifics of that match. But there's nothing at all in the science that would suggest it won't be useful for therapeutic decision makings in mental health decisions. What's really interesting, and indeed some studies are going on now in the National Health Service and in association with Somologic and others that are working in this field, is seeing about genetic or proteomic signatures that are predictive of or early diagnostic of mental health conditions. You know, is there a protein signature for bipolar disorder? Is there a protein signature characteristic or a genomic characteristic that is predictive of the likelihood of developing schizophrenia? Or, yeah, I mean, go on and on through the ICD-9 codebook. But, you know, that's certainly where this is all moving. It is agnostic about the field, because basically what you're doing is mapping the intracellular workings of the body. And we know that it is not situations that produce schizophrenia. It's not external situations. They make them worse or aggravate them, but depression, etc. There are predilections that we have and abilities that we can build to help resist those predilections if we know in advance, for many of them, not all. But, you know, so the short answer is yes, this can be used. A lot of work to do. We're a long way from being able to do that, of course. But the exciting thing is when you go into a community, and let's just take an example. We know that in underserved and underrepresented communities in the country, the frequency of adverse childhood events is much higher. And unfortunately, the frequency of adverse childhood events is predictive of several things. First of all, that the child was going to suffer more likely from chronic diseases and mental health diseases, educational problems, behavioral problems in school, etc. We know that. But it's also interesting because adverse child events during childhood are also predictive of the probability of developing chronic illnesses in adulthood. So if we have a way of finding out early on what the intracellular mechanisms are associated with the adverse childhood events, the disturbances of ACEs, so that we don't have to rely on parents reporting about things and all the sensitivities that are involved in all of those things with adverse childhood events, very hard to get the information you need to establish that that's what's going on in a particular household, because they're adverse events, drug abuse, physical abuse, I mean, you can go on and on about this, and mental health problems, absent parents, all those sorts of things that are contributory to adverse childhood event. It has an impact on the body. And actually, early studies indicate what those are. But what we want is some sort of careful diagnosis and careful mapping using these new emerging tools so that we can more sensitively and earlier figure out, okay, who are the kids at risk? Rather than trying to treat every child in a community, which is not what's going to happen, but we want to make sure we get to the ones who are most at risk. And come up with the interventions and work on the interventions that are shown to have the outcomes we look for, but also shown to alter those, whatever it is in the genomic or proteomic patterns of the cell that move somebody in a positive direction. So it's very exciting, Jessica, what can happen in the behavioral area.
It's very interesting. Yes, very, very interesting. Thank you so much.
Still really new. I mean, still really new. So.
All right, everyone, any final questions you may have for Dr. Lawrence, Dr. Warren, or the admissions team?
Kelly or Angel, Sabrina, do you have any questions?
Dr. Lawrence. This is Sabrina. I apologize. I'm on my commute home from work, so I have you on my phone, so I don't have my video on.
Oh, that's okay.
But
That's
I
okay.
did,
Go
as
ahead.
you were talking, I was really thinking more about, I know this precision medicine is new, as well as precision health, but do you have any insight into the intake of what insurance companies are thinking about or kind of leaning towards when it comes to this new concept of health?
They hate it. They're not, it's going to be a battle to get them to cover it for individual patients. And of course, when you get into a community, you have to have other vehicles for providing the support that enable you to work with a community to do these kinds of studies, these kinds of data gathering things. So the medical insurance field is inherently resistant to anything new and demands an enormous, they set a very high hurdle for being able to say, yes, we're going to go forward with that, or we're going to cover that. Now, what we're doing, and it's a great question, in the case of cancer treatment, if you think about the cost to the insurance companies as well as to the individual patient of going down the first line to the second line to the third line to the fourth line drug, and where 2 or 3 of them are not going to work because you've done the kind of matching process that I described with precision medicine, you would think that insurance companies would love that because it saves them money. They're not wasting money buying drugs that aren't going to work. Yeah. Forget for a minute the impact or the importance for the patient, which is the primary thing. But the insurance companies are still really skeptical about it because everybody who comes to an insurance company saying, I want you to cover this, they look at with jaundiced eyes because they've been burned a lot. They demand a lot of information, a lot of data, and a lot of conversation. And that's one of the things in any new drug or any company that's building new drugs or coming up with new approaches like this has to figure out ways to communicate and work with the insurers who are paying for it. And that includes, by the way, Medicare and Medicaid, not just the private insurance companies. All of them are slow adapters. They want lots of evidence. And even with the evidence, they often are slow to make the changes because it may means paying more upfront to do things, even though the downstream payoff might be there. So you have to come up with very careful econometric information to prove the case, as well as the clinical information, ease of use, doctor's acceptance, all of those kinds of things the insurance companies go through in trying to decide yes or no. So I said sort of glibly, no, they hate it. But the truth is, that is the role that insurance companies have. They're gatekeepers on new technology, new approaches. And every new approach, every new device, every new drug, every new treatment has to go through that gauntlet in order to get the insurance companies to agree to it. And that's a different gauntlet than getting approval from the Food and Drug Authority. That's another pathway you have to go through. Does that answer your question, Sabrina? Don't crash.
Yes, it does. Thank you so much. And just a quick follow-up question on that. What do you foresee, or how do you foresee this movement kind of improving or helping those that are uninsured? I know that, a lot of underserved, underrepresented communities rely on Medicare and Medi-Cal. And there's a lot of tests, a lot of medical care that really is kind of pushed or put on hold if somebody isn't insured.
That's exactly right. And part of what we're trying to do here, the argument for why we want to apply precision health to those communities, especially the underserved, underrepresented communities, is that's where the burden of preventable illness is highest. That's where health is the poorest. That's where the opportunities to improve health are greatest. And it's a yes and kind of answer to your question. Yes, we have to be able to provide care for the people who are sick and hurting. And the fact that this country doesn't do that for every citizen, for everybody, or even everybody who's here, whether citizen or not, is, to my mind, a shame that the country still bears. So let's get that off the table. But what is really exciting about what we're trying to do in community medicine is we're trying to use these developments in medical science and healthcare science that I've been describing, and these tools to be able to intervene effectively in those very communities, to be able to start changing those communities, enabling those communities to make the changes in the conditions that are producing so much illness, so many injuries, so much poor health. And nobody from the outside can do that, by the way. I can't come into a community that is not familiar with or sees me as an outsider, as an other of some sort, an old white guy, whatever I am. They see me in that form. I can't come in. I don't have the credibility. I don't have the trust of the community. But the people from the community need to be doing that, and that's why we're focused on admitting people to our Masters of Science in Community Medicine from the underserved and underrepresented communities, because they're the ones who can work in those communities. But even they can't do it alone. You cannot change behavior. You cannot change the social and economic and environmental conditions alone. You need a community that's activated to start advocating for that kind of change. It's slow, it's hard, but if we don't do it, all we're going to be doing in the United States is taking care of broken bodies and injured bodies, like we're doing now. And it's unsustainable, and it's cruel. And the saddest thing of all is much of what we have to treat and take care of is preventable. We know how to do it. So our crime is not doing it as a country. That's that, and I'll get off my soapbox. I've watched this for an awful long time, and it really is, it is infuriating to think that we do this. I'll just give you one analogy. If we apply the American medical care system to the airline industry, what we would do is prepare a whole lot of people and a whole lot of facilities to take care of victims of air crashes, but airplanes would still be falling out of the sky. That's what we do in medical care. We just take care of an awful lot of people whose bodies are broken or injured or sick. And we do it pretty well for the people who have the money to get to it.
Very insightful. Thank you so much, Dr. Lawrence.
Drive carefully.
Oh, yeah, I pulled over. I wanted to make sure I was able to listen a little more thorough.
Good, Sabrina.
Thank you.
Angel or Kelly, do you have any questions?
I don't have any questions, but I just wanted to say thank you, because this has been extremely informative and insightful and kind of crazy to think about. So
Isn't it?
that we don't already do it already. So thank you.
Well, didn't you say you were going into genetic counseling?
Yeah.
Yeah, well, you are right at the cutting edge, kid.
Yeah.
That's
one of the things I like about it too.
Yep. Oh man, it's such an exciting field. And it's not just genetic counseling. The counseling is really intracellular pathway counseling. Genetics is one part of it, and a big part of it, of course. But as I said, proteomics is the matching field with genomics, and together they're just enormously powerful.
Yeah. Thank you. Yeah.
You bet. Well, good luck with everybody on your careers. And I'm delighted, Jessica, that you've talked about joining this, looking at the Masters of Science in Community Medicine program. We're very excited about it. And there's just so many overlaps between that field and the rest of you, the fields that you're talking about wanting to go into. There's just so many overlaps. You can look at me and see that I've been through a few wars together, over the decades that I've been in healthcare. I often say to people who are at your stage in your careers, you are at the cusp of what is, in my experience, the most exciting period in healthcare that we've had in the last 100 years, because of what's happening scientifically and socially, and the way we're being able to develop the tools and skills that are needed to be able to intervene with communities and individuals in a way that we just haven't been able to before. It's extraordinarily exciting.
Well, thank you so much, Dr. Lawrence, and thank you so much, Dr. Warren, for being here today. And everybody, if you have any other questions, please feel free to email me. I can answer any questions on admissions or any other questions you may have. Thank you again for being here this evening. I hope you all have a wonderful rest of your night and stay safe. Thank you.
Yes, indeed. Take
Awesome.
care, everybody.
Thank you so much.
Everyone.
Thank you.
Thank you.
Thank you
Bye.
so much, Dr. Lawrence.
Thank you.
Nice to meet you.
Thank you all.